So we're going to talk about nurse practitioners in critical care transport. Very new in the field, and just a quick background: NPs are used throughout critical care transport in the Cleveland area, but more commonly they're found in the inpatient setting. They practice in the emergency room, in the intensive care unit, the outpatient setting, and they fill a whole bunch of roles as that mid-level provider between the physician and the registered nurse. They act as providers, and then they can write orders, interpret diagnostic data, interpret imaging, perform procedures, and are an integral part of the care team. At a few select programs, like we said here in the Cleveland area, especially critical care transport teams utilize nurse practitioners to bring a higher level of care, patient care to the bedside. And many times they're employed by the hospital system, and so they're familiar with hospital policy and procedure and act as an extension of the intensive care unit or ED, which they come from. And I'm going to look at some of their uses and then provide some information on where I think we can maximize their role moving forward. As has been discussed in earlier papers and earlier discussions, the typical transport model is a nurse, registered nurse, and a paramedic. And in a few select programs, we're to look at the nurse practitioner-led crew, which is usually a nurse practitioner and a paramedic, or a nurse practitioner and a nurse. For especially sick patients requiring mechanical circulatory support, the nurse practitioner may be a third crew member to augment that nurse practitioner paramedic standard team. The nurse practitioner is a full crew member, a full flight team member, and serves as a full crew member, meaning that they are held to the same standards of the flight team. They have the same ongoing educational requirements, same CAMES requirements as far as their documentation, their experience, and responsibilities to the flight team. Secondary responsibilities and duties, apart from clinical care, vary from program to program, but this is where the nurse practitioner can excel and can offer things that the standard crew member, the nurse, the paramedic may not be able to offer. Some of the ways that they're used and some of the things that they can provide that are different than other places are their clinical care. They are autonomous clinicians. And for the most part, you can what if, and there's always one-off scenarios, but they don't require medical control, no protocols. They can assess and integrate data together to make evidence-based decisions. And they can also tweak those decisions based on individual patient presentation. And no two patients are alike, and it's hard to practice algorithmic care, especially in critical care transport. So the NP is able to synthesize all the information and their assessments together to make the best decisions for the patient in front of them. They are more familiar with laboratory results, imaging studies, and can interpret all of this to help with their decision-making process. They may be credentialed in advanced procedures, including, but not limited to, advanced airway management, tube thoracostomy, central line and arterial line insertion, pericarditis entesis. They may be able to perform some other advanced skills program to program, but it would really be dependent on how the medical director felt and what they thought was necessary. Examples of that would be perimortem C-section or some other advanced lines such as ROBOA or even ECMO cannulation. Like I said, it's a very gray area and would depend on individual programs. They also, one thing that I think separates the NP from the registered nurse paramedic crew and would be adjusting settings and parameters for durable mechanical circulatory support, ECMO, and mechanical ventilation, whereas the registered nurse paramedic crew may not be comfortable adjusting flows or sweeps on an ECMO circuit and or RPMs on a VAD, or even the P level, the power level on an Impella, or some of the advanced mechanical ventilation techniques such as high frequency oscillatory ventilation or APRV. The NP brings an advanced level of knowledge, education, and experience with those devices and could make some of those setting changes in real time without requiring consult medical control. As far as education is concerned, this is both education of the NP and education they can provide to their crews. All NPs have a minimum of a master's degree, and many are doctorally prepared. And with their advanced education, they not only have experience in classes in curriculum development, in providing quality assurance and evidence-based practice, but they can then translate the education that they've received in evidence-based practice, in current use of care, in advanced assessment, in advanced pathophysiology to the benefit of their crew members, and using them as a part of staff education, using them as a competency validator for procedural skills, and using them within simulation scenarios provides an advanced level of training and understanding to the staff member, and allows them to benefit from the advanced education of the NP. And having them run the skill stations, run the simulations, they can provide feedback that potentially their other colleagues may not be able to. And it also helps to offset some of the medical director responsibilities, because the NP can provide that mid-level of care, that mid-level of understanding, and translation of what the medical director wants to do without the medical director being physically present. Chart review and quality improvement. We all know that quality assurance and improvement are integral to ongoing practice. It's a CAMES requirement, and it helps us be the best possible clinicians. And improving charting and having an NP oversee that can provide some legal protections, ensuring that we're charting legally what we should be, and ensuring that we're within our scope of practice. But we're also ensuring that evidence-based practice is occurring. We know, for example, if you're having an NP over the ventilation committee, we can ensure that lung protective ventilation strategies, low tidal volume, minimizing driving pressure, things that we know are best practice is actually occurring, and providing feedback when it's not, to ensure that our trajectory moving forward is always heading in a positive direction. We can also use charting reviews for quality improvement and quality assurance, meaning that if we identify an area of weakness, the NP can lead a team to ensure that moving forward, perhaps charting heights for adequate vent settings, which was one of the limitations in the air vent study that was done. They found that only 6% or so of charts had proper heights charted, and so that's an area that the NP can lead to quality improvement to ensure that we are doing what's evidence-based, and they can interpret those results and adjust the quality improvement plan moving forward. Because of their advanced education, either the master's or the doctoral degree, they're prepared to do some research, and their efforts in quality improvement can be published and can add to the research output of the program and of the hospital. And then chart review, again, just provides adequate and evidence-based protocol development. So if we need a protocol for Impella, if we need a protocol for even any arrhythmic therapy, utilizing chart review and quality assurance and implementing best practice guidelines into that can ensure that our protocols are up to date. Revenue is one of the things where we need to ensure ongoing and incoming revenue to offset the cost of the NP. The NP is a little more expensive than the standard registered nurse paramedic crew, but can be offset in different ways. Billing for critical care time is a little bit of a gray area, but it allows for some reimbursement spent on patient management during transport. One can also charge higher lift fees and higher loaded mileage fees for having an advanced practice provider on board, which can offset some of those costs. And then alternate forms of revenue generation, like telehealth consulting or tele-ICU, e-ICU, whatever name you want to use, having part of the FTE of the nurse practitioner being coverage of that ICU could either bring in a standard fee or an hourly fee, or billing for critical care time, but having to cover e-ICU or tele-ICU could bring in some additional money, as well as covering online medical control. If you had somebody in a communication center, that again offloads other physician responsibilities and allows them to provide more care to their patients, and bringing in, not only that 80% of revenue, but that full 100% of revenue, because all their time is dedicated to direct patient care, because you have an NP covering online medical control, and it offsets some of those physician responsibilities. Further use in the inpatient environment could provide additional revenue, and this is where I think the best thing would be is to split the FTE of the flight nurse practitioner or the critical care transport nurse practitioner between the flight environment and the inpatient environment, because as an inpatient provider, they can really, for the critical care time, they can bill for procedures, and And so not only are they gaining extra experience and education, but they're also able to bill on the inpatient side to augment what's already going on. So why I think it's important to work in the inpatient setting is critical care transport involves many high acuity but low frequency transports where mechanical circulatory support, uh, different forms of shock, pediatrics, obstetric care, some of the advanced trauma, advanced STEMI or aortic dissection. Like, CCT runs the gambit, and you see kind of a little bit of everything, but maybe not as frequently. And so having inpatient exposure to the same pathologies ensures that you're practicing evidence-based care and up to date with the most recent literature. By practicing in that inpatient setting, you also get an understanding of longitudinal care and where this patient is headed. And what's great about that is then you can, by knowing where the patient's headed moving forward and what their patient course is going to look like, therapy and best practice can be started in the field prior to the patient even arriving into the ICU or the ED. You also get more time to perform procedures and maintain proficiency with arterial line placement, central line placement. That's been discussed. Maybe those don't happen as often in the critical care transport environment. But when they do need to happen, the patient's usually ill and it's a time-sensitive emergency. So increased exposure in the ICU and the ED allows one to stay competent and proficient with procedures. And as we talked about, they can take their inpatient knowledge and experience and translate that back to the setting. And as we talked about earlier, most of the nurse practitioners are hospital-based. And so if there was hospital A says, we want aortic dissections managed in this one way, and their surgeons feel a certain way about either medications or formulary or the way that they want blood pressure managed, then those NPs, having practiced in an inpatient setting, can translate that to the critical care transport environment, ensuring that the patient, from the minute they arrive at the bedside, is receiving the level of care and expectation of the receiving facility. So the proposed rotation that I would have the critical care transport NPs go through is split 6 months and 6 months, and that's really to maximize inpatient exposure, but also for splitting FTE. Half an FTE is spent inpatient, half an FTE is spent via the flight or critical care transport team, and that also marries up 2 NPs. One of them is always on the transport team, and one of them is on the inpatient side, and they rotate each and every month. And so they would do 6 months of critical care transport, 1 month of trauma and the emergency room care, and that would allow for laceration exposure or laceration repair, trauma ATLS workup, managing some of the cardiac arrest or STEMI, that early immediate action steps. They do a month in the surgical ICU. They do a month in the cardiac care unit, a month in the NICU, and then 2 months of rapid response, because rapid response is similar to the transport environment in that you're managing somebody who you know little information about, that's in an acute emergency state, and you're not only organizing their care and ensuring the transfer to the ICU or wherever they need to go, but it's almost an extension of the critical care team. And so with this model, you spend 8 out of the 12 months or 2/3 of the year in that transport or rapid response capacity. And then the other 4 months are your kind of ICU blocks, where you're not only generating additional revenue, but you're ensuring that you're up to date with best practice, and you're exposed to different pathologies that we don't see as often in the transport environment. So some of the benefits that I think this would bring would be constant exposure to the latest critical care practices, neuro-intensive care, cardiac intensive care. The needle is ever changing and what we're supposed to do and blood pressure targets and things like that. So constant exposure ensures you're up to date with the latest practices. You get that increased procedural competency by performing those ICU procedures more often. And I think you get integration of the critical care team into the inpatient hospital setting. And you can form those relationships with the provider so that if you had a very challenging patient and you want to call a provider in the inpatient setting, you've already had that rapport, you already have that relationship built. They know you, you know them, and you're seeing more throughout the hospital and can get more buy-in from perhaps the inpatient units. You also help to augment staffing for those inpatient units with a competent and skilled provider. They know that you're coming in and maybe need a little bit of orientation, but not a full-blown orientation. and you were seen as more of an asset than a liability when you come in and augment their staffing model, and provide an additional provider to, again, offload some of those physician responsibilities, but you don't need maybe perhaps as much babysitting as somebody else. And it allows the inpatient staff and units to influence transport practices, because of that rapport that you have built. And so while it is a little more expensive and you don't have that NP providing 24/7 transport, rotations, I do think that spending half of their time in the inpatient setting would benefit not only the hospital and the transport team, but at the end of the day, benefit the patient because it ensures that best practice is carried from the bedside into the ICU. And then perhaps the inpatient settings can help augment or offset some of that FTE charge.
Tanner, I think it's worth a pause here for some discussion because this is a very interesting the rotation. So I think there's no doubt that for the NP, for the transport world, there's benefit from this exposure. And like you said, the question is, how about for the MICU, the CCU, the SICU, and the rapid response? The other thing to consider that I've thought about is to transport people are generally okay floating, right? It's not ideal, but they're good in the unorthodox environment. That's what they do. Maybe they go during their 6 months off to wherever the need is. And yes, this NP is not, let's say they're in the SICU. They're not a seasoned SICU NP. They have some NP experience. So not only are they there, but they're adding value because they're short-staffed anyway.
Sure.
So
Sure.
what are your thoughts on, like, instead of that, they're more of a float NP for that 6 months off. And then they go wherever the gap is, like, all right, yeah, ideally I'm the ICU. I'd rather have a SICU NP next to me, but we're short here. I'll take that's just another consideration there. Yeah.
Having a competent provider, could be the world of difference. And I think we'd have to talk to Keith, but I believe at Vanderbilt they have an ICU float NP position. It sounds like some of their NPs do fill in the ICU,
Yeah.
and so I'm sure that they're doing it and it's bringing benefits. So absolutely, perhaps instead of defined rotations, they form in more a floating capacity, and then that's again, it's just exposure.
Right. Like the bucket of FTE comes from the hospital, maybe a little bit from each one of those units, but when they have a gap, somebody leaves, somebody has on vacation, somebody's having a baby. All right. We can't necessarily hire a new NP, but we'll bring in the transport NP to fill that gap for a while.
Sure.
That's another thought that I've thought, and yeah. Nice job. I just wanted to pause there before we skipped it all and then, but
No, that's good. I think it's good, and it would also allow for, especially in today's day and age, if the NPs are credentialed in the inpatient setting, then if there's overtime available or they want to work, some extra time, if they're credentialed everywhere, it makes it nice and easy to pick up shifts and help with staffing and a little extra money for the NP.
yeah, and on the transport side, they have a rapport, like you said, with all these different departments. So if these departments don't like how patients are coming in, they can just reach out to that person. The float NP is a new thought. We'll see. All right. I think we were done with the rotation and then on benefits to inpatient critical care or inpatient care.
Really the benefits to inpatient care, want to acknowledge all the people that have helped with this, but I think that the float NP or the splitting of FTE between transport and inpatient is really how the future. And I think that would be, it would also help augment, somebody's argument to say we want a transport NP, and maybe not off the bat they say, hey, we need to hire all these FTEs for just the transport team. We say, hey, we want to hire all these FTEs, but we're going to give them half to you in the ICU. And that also could help with your recruiting pool because everybody wants to do flight, but if hey, I've already got a great ICU NP, that would help with transport, they're already known to the system. And you can learn how to do flight and critical care, especially if you've got that great ICU background. It's kind of what we want for the nurses. We want them to have that ICU background. So if you take a really good ICU NP and just put them into transport and flight, you know that you've got a competent, skilled provider already. And so when you're saying we want all these FTEs, but we'll split it with the inpatient side, everybody kind of wins.
Yeah. Yeah, there's a lot of ways to do it. I like your proposal. Of your proposal, the hardest part was getting buy-in from each of them, but if you defined it as we go where the gaps are, and that might be a little easier to sell.
And the other thing with a program like this, if you think about, I will use Vanderbilt again because I think he said they had around 30 NPs. That way you can ensure with 30 NPs that when half of them are working inpatient, you can tell the SICU or whatever, hey, we're going to give you an NP 6 months out of the year or something like that. It's not just a couple weeks here where it's more of a burden than a benefit. With so many NPs, if you had a core group of ICUs or the ED, you can almost guarantee that they'll have an NP throughout the year. It's going to be it's just like the residents rotating, but you can ensure full coverage.
Yeah, or maybe between, let's say you have 12 NPs working. I'm just throwing this number out there because it's easy. You have a month of, and maybe you want 50-50, but maybe you can't get 50-50. But even if you had a month of kind of rotating through / office / helping the inpatient side or whatever it is, it's an interesting thought that we're not going to figure out in 5 minutes, but that's the perfect type of person who's comfortable going to different places, out of the norm. This looks really good, Tanner.